All right, we're going to go ahead and get started. Everyone will just join as we're moving along. I want to thank you for joining us for our fourth session on chronic kidney series grand rounds. This is the slowing CKD progression, medication optimization in the primary care setting. Let's see here. I got a bunch of windows open here. Um, so this is, of course, the accreditation statement stating that there's no commercial support disclosures and financial relationships, same as what we always get. This is the claiming CME credit. There is an activity code. There's also the QR code that you can scan. This PowerPoint, it'll be in a PDF, but that will come to you after the presentation, along with the AIP form that explains how to claim your credits. Follow those directions on there, and just remember you have 30 days to submit your request for the CME, and you cannot get the credits after that 30 days. So with that, Chantel's going to show her own. It's my pleasure to introduce our presenter, Chantale Daifi. Did I do that right this time?
You did, Terry, you did.
Yay! Dr. Daifi earned her Doctor of Pharmacy degree from Purdue University and completed a PGY1 pharmacy practice residency at William Beaumont Hospital, which of course now is Corewell Health. She is the clinical pharmacy coordinator for dialysis at Henry Ford Health, where she specializes, oh, in the care of patients with chronic kidney disease and end-stage kidney disease, and works to expand pharmacist involvement in dialysis centers. Dr. Daifi is an educator, national speaker, and published author with expertise in kidney disease management. She is actively involved with the National Kidney Foundation, serving on the Michigan Scientific Advisory Board and supporting national incentives to advance kidney care through optimal medication management. Please join me in welcoming Chantale Daifi.
Thank you so much, Terry, and thank you guys all for being here today and listening to the presentation, a very important presentation, and I hope this is very valuable to you. Today, I will be presenting to you guys on preventing chronic kidney disease progression from a pharmaceutical perspective. But before I start, I just want to let you guys all know that I do not have any financial disclosures or conflict interest with any of the stuff in this presentation. Today, the primary objectives are going to be to recognize the role of primary care in managing chronic kidney disease progression. We're going to be identifying target goals for blood pressure and glucose control in patients with chronic kidney disease. We're going to also look at identifying medications that are proven to slow chronic kidney disease and progression and reduce cardiovascular risk. We are going to, by the end of this presentation, identify patient safety considerations, including medications to avoid and adjust. And then we're also going to look at when is the appropriate time to refer to nephrology. So let's begin by being aware that chronic kidney disease is a public health issue. There is a low recognition of chronic kidney disease, which has been a public health problem. Chronic kidney disease is associated with substantial morbidity. It impairs quality of life. It can shorten life expectancy, and it can cause excessive healthcare costs. There are about 30 million Americans, actually over 30 million Americans with chronic kidney disease, accounting, which is about 26.1% of expenditures for Medicare beneficiaries. In Michigan, there are actually over 1 million people with chronic kidney disease, and this is 1 in 7 Michiganders. However, awareness still remains very low. Only 10% actually know they have it because chronic kidney disease is easy to miss. Most people have no symptoms until their GFR is significantly reduced, and then it's actually too late to prevent these adverse outcomes. The prevalence of medication-related problems increases as chronic kidney disease progresses because the medication usage increases. Patients with stage 3 and 4 chronic kidney disease are prescribed approximately 68 medications, while patients with stage 5 are prescribed an average of 12 medications to treat on average of 5 to 6 comorbid conditions. These patients tend to have very chronic medical conditions. putting these patients at risk for high medication-related problems, and it's actually associated with significant cost to the healthcare system. There was a meta-analysis of the association between chronic kidney disease and the risk for all-cause and cardiovascular mortality that demonstrated an exponential increase in absolute risk for death with decreasing kidney function. The meta-analysis of cohort studies involving over 1.4 million individuals yielded an association of not only a low GFR, but also higher albuminuria with cardiovascular disease. That's why chronic kidney disease must be considered one of the strongest risk factors for development of chronic kidney disease. The current treatment strategies for patients with chronic kidney disease and type 2 diabetes focus on cardiovascular risk reduction, blood pressure control, and glycemic control. So, for example, the current KDIGO guidelines recommend using ACE inhibitors and ARBs in patients with chronic kidney disease and diabetes who have hypertension symptoms. There have been emerging treatments such as finerenone and SGLT2 inhibitors that have demonstrated clinical benefits in terms of preventing cardiovascular disease in patients with chronic kidney disease and type 2 diabetes. Chronic kidney disease may not be cured, but in many cases, now more than ever, we can actually reduce the risk of progression to kidney failure, heart failure, and death with adding these new therapeutics to prior standard of care. So, for example, adding an SGLT2 inhibitor when added to a standard therapy with a RAS inhibitor in patients with chronic kidney disease with or without diabetes can protect the kidneys with almost a 40% reduction in risk of substantial decline in onset of kidney failure and the need for dialysis or a kidney transplant by up to 15 years if you actually start it early. It can also reduce hospitalizations for heart failure, kidney, and cardiovascular deaths. However, despite very convincing evidence of benefit, the uptake of these effective agent remains concerningly suboptimal everywhere. There is an unjustifiable gap between what we know works and our practice. This figure here shows proportions of people living with hypertension, diabetes, and chronic kidney disease who are aware of their diagnosis and are on the appropriate treatment. Globally, it's actually estimated that 1.3 billion people have hypertension, 547 million have diabetes, and 697 million have chronic kidney disease. But awareness of these conditions is low, and when treated, even smaller proportions of people are actually being treated appropriately. The top right figure demonstrates people with chronic kidney disease diagnosis who are receiving guideline recommended care. The ranges are actually indicated with the error bars. So why do we have these gaps in care? There's a term called clinical inertia, and that refers to low implementation of guideline-directed therapy. Knowledge about these guidelines and therapeutic targets is suboptimal among primary care practitioners. They may view these guidelines as conflicting or confusing. And in addition, given the diverse patients that are being seen in the primary care, adherence to these guidelines for every patient problem is hardly feasible. Furthermore, providers may not be confident in using these certain medications, such as SGLT2 inhibitors. Non-specialists and specialists are less confident in the use of the medications and they worry about their side effects, lack of time for necessary follow-up, or they can actually view them more for non-kidney indications. And lastly, they may also hesitate because of unaffordability for the patients. Many medications used in the management of chronic kidney disease are actually very expensive, placing a significant financial burden on patients. Clinicians everywhere are working under time pressure imposed by cost efficiency demands and large patient numbers. In addition, in some settings, extra time is required for negotiation of pre-authorizations or requests for medication assistance which can delay or hinder appropriate prescribing. Also, there's limited availability of generic medications. While generic medications are often less expensive than brand name medications, most of these medications are still not even available as generic medications, and that can put the cost at very high. So what can you do to help recognize chronic kidney disease? Part of our consideration when looking at chronic kidney disease is achieving the goals of therapy. The first goal is to delay the progression of chronic kidney disease and decrease albuminuria. The second would be to minimize the risk of cardiovascular disease and cardiovascular events. Another goal of therapy is to optimize the use of certain medications that are beneficial in chronic kidney disease patients while managing their side effects, such as hyperkalemia per se. And lastly, we want to encourage appropriate and timely referral to nephrology. To help achieve these goals, we can start by slowing chronic kidney disease progression by reducing albuminuria. We can do so by incorporating these medications that are beneficial to the chronic kidney disease population while managing side effects. As you all know, hypertension is the second leading cause of chronic kidney disease after diabetes. Chronic kidney disease may cause worsening hypertension. Individuals living with chronic kidney disease are at high cardiovascular risk. So ACE inhibitors and ARBs have demonstrated benefits in individuals with chronic kidney disease in addition to improving blood pressure control. These include slowing chronic kidney disease progression, decreasing albuminuria, and reducing cardiovascular risk. Starting in 2011, there have been many clinical practice guidelines published that address the treatment of hypertension. Although opinions differ in areas lacking large randomized control trials, agreement exists in setting a blood pressure goal of less than 140/90 for most individuals. The KDIGO blood pressure work group got together, expanded their pool of evidence beyond looking at long-term randomized control trials in hypertension and included meta-analysis, systemic reviews, and select randomized control trials with outcomes related to kidney disease progression. Review of this evidence base supports a lower blood pressure goal of less than 130/80 for individuals with CKD who have moderate to severe albuminuria, either with or without diabetes. They then updated their guidelines in 2021. So after 2012, so in 2021, they updated their guideline and includes recommendations for blood pressure management for individuals who are not on dialysis. And this is specifically for chronic kidney disease. So they compared systolic and diastolic blood pressure targets of less than 130/80 for those with albuminuria and less than 140/90 for those without albuminuria in the 2012 KDIGO guideline. And they include the recommendation that adults with CKD and high blood pressure who are not kidney transplant and they are not on dialysis be treated to a target blood pressure goal of less than 120 based on a standardized office blood pressure measurement. And this is a huge update from the 2012 KDIGO guideline, which basically advised clinicians to target a blood pressure of less than 130/80 for patients with albuminuria and less than 140/90 with patients without albuminuria. And the new goal is also lower than the 130/80 target in 2017 American Heart Association guideline. And these goals are based off the SPRINT trial, which basically showed a cardioprotective and survival benefits in these patients. The new guideline presents also with an algorithm that therapy with either an ACE inhibitor or an ARB is recommended for patients with CKD to prevent or decrease the rate of progression to ESRD. An ACE inhibitor or an ARB should be the first-line agent for antihypertensive therapy for CKD patients, and it's actually recommended for patients with albuminuria, regardless of needing blood pressure control. Angiotensin causes greater vasoconstriction of efferent arterioles than afferent arterioles, and it leads to glomerular hypertension. So this leads to hyperfiltration, and prolonged hyperfiltration leads to glomerular structural and functional deterioration. Both an ACE inhibitor and an ARB can reverse this process and delay renal disease progression. If an ACE inhibitor or an ARB is not effective on its own to control the blood pressure, then a thiazide or a dihydropyridine calcium channel blocker, such as amlodipine, may be added. It should be noted, though, that a dihydropyridine calcium channel blocker should not be prescribed without the concomitant use of ACE inhibitor or ARB, since their sole use may lead to greater hypofiltration and albuminuria. So we know that patients with chronic kidney disease have a much higher risk of hyperkalemia than the general population. The incidence of hyperkalemia increases as the stage of CKD progresses, with the highest risk at stage 4 and stage 5. What's most scary to the clinician is the arrhythmia potential, which often limits the use of a RAS inhibitor in patients with kidney disease or heart disease, where these drugs have known clinical outcome benefits. And because of this risk, we are often found discontinuing the medication. This was shown in a study of 556 chronic kidney disease patients who were being treated on a RAS inhibitor. What they found was 51 patients experienced an episode of hyperkalemia during the follow-up period. And among those 51 patients, 61 patients 61% of patients changed their RAS inhibitor treatment prescription. 45% discontinued the treatment, and for one patient, they were prescribed a reduced dose of these agents. So with this deprescribing, this really withholds the benefit that the medication has from our patients. The guidelines suggest that it's recommendation that if a potassium is mild, that we should attempt to measure or reduce potassium rather than decreasing the dose of ACE inhibitors or ARBs or stopping it altogether. The KDIGO guidelines on blood pressure discuss hyperkalemia and suggest not withholding a RAS inhibitor because of hyperkalemia. In particular, to use a combination of pharmacological and non-pharmacological approaches and having monitoring strategy. Along with the European Society of Cardiology, NKF, Italian Nephrology Association, all those guidelines basically state to not stop or reduce the dose of RAS inhibitor because of hyperkalemia unless you exhaust all options to manage the hyperkalemia, because those RAS inhibitors have such good benefit to the patients with CKD. And that's a consistent message between these other groups as well. And it's important to know that there's no hyperkalemia guideline per se. This evidence-based comes out of adjacent guidelines such as hypertension or diabetes. Also, no evidence-based stepwise or prescribed approach to manage hyperkalemia in CKD. So therefore, the best approach is the one that's patient-specific in nature. We have potassium binders to help increase the use of ACE inhibitors or ARBs. So there was a systemic review meta-analysis to look at potassium binders with improved efficacy in patients with heart failure. A total of 1,432 patients from 6 randomized controlled trials were included, of whom half of patients received potassium binders and the other half didn't. And in patients with heart failure, potassium binders increased the use of RAS inhibitor and reduced the risk of hyperkalemia. There was no difference between groups for individual outcomes of all-cause mortality. A few monitoring parameters to look at with the use of ACE inhibitors and ARBs. So when we know that the ACE inhibitors and ARBs, one of the things is when you're using it to look at changes in blood pressure, serum creatinine, GFR, and potassium. These should be checked 2 to 4 weeks of initiation or when increasing the dose of ACE inhibitor and ARB. An increase in serum creatinine, if occurs, will typically happen within 2 weeks of treatment initiation, and it should stabilize within 2 to 4 weeks in the setting of normal fluid and sodium intake.
Content laying on the floor or what?
Since the reduction of intraglomerular pressure has long-term benefit, it may cause a small rise in serum creatinine in the short term, since GFR is directly correlated to intraglomerular pressure. A rise of up to 20 to 30% above the baseline is acceptable and not a reason to withhold treatment unless hyperkalemia develops. For most patients, a potassium level of up to 5.5 and a serum creatinine increase up to 30% from baseline are acceptable within the first 3 months with close monitoring. However, the ACE inhibitor and ARB may need to be reduced or discontinued if the potassium level remains elevated above 5.5 or the serum creatinine continues to rise or does not improve. It's important to note also to avoid combination of ACE inhibitor and ARB. There hasn't been any data to show an increase in, there has been data to show an increase in adverse events, particularly impairing kidney function and hyperkalemia. In addition, dual therapy with ACE inhibitor ARB is not recommended because there has been studies to date have not shown any clinical significant benefit on overall mortality for dual therapy over monotherapy. The on-target trial study showed that dual therapy increased the risk of worsening of kidney function and hyperkalemia. Moving on to diabetes management and chronic kidney disease, among glucose-lowering drugs, metformin and the sodium glucose co-transporter 2, known as SGLT2 inhibitors, are recommended as the first-line treatment, whereas the GLP-1 receptor agonists are a second-line option for patients with type 2 diabetes and chronic kidney disease. These recommendations for the SGLT2 inhibitors and the GLP-1 are supported by a meta-analysis of cardiovascular outcomes trial that included patients with CKD stages 1 through 3 and are also supported by dedicated kidney outcome trial for canagliflozin in patients with type 2 diabetes and chronic kidney disease. The SGLT2 inhibitors have an important role in the management of kidney disease. They were initially approved for the management of diabetes. In these diabetes trial, cardiovascular and kidney outcomes were actually secondary outcomes of interest. The SGLT2 inhibitors demonstrate improvement in both of these endpoints. And this is exciting as diabetes is a leading cause of chronic kidney disease and end-stage renal disease, and that the SGLT2 inhibitors can not only improve the outcomes for diabetes, but also for cardiovascular and kidney outcomes. Supporting the use of these SGLT2 inhibitors is a key component of optimal medication management in those with kidney disease. The SGLT2 inhibitors here in the table are recommended for GFR with greater than 20, in addition to the first-line meds shown here. The only two that are still not approved for chronic kidney disease use are the last two. And these, to know, SGLT2 inhibitors should be continued until dialysis with regular monitoring and adjustments to optimize care. So when the patient starts on dialysis, you can go ahead and discontinue the medications. So what do the guidelines say? The American Diabetes Association and KDIGO released a joint consensus document for the management of diabetes and chronic kidney disease in October of 2022. They recommended that in conjunction with lifestyle modifications, first-line drug therapy includes evidence-based SGLT2 inhibitors, irrespective of current or prior metformin use. SGLT2 inhibitors are indicated for people living with chronic kidney disease with or without diabetes, as well as those with or without heart failure. That's just how much benefit or good they are. They are the backbone of therapy for management and prevention of heart failure. However, SGLT2 inhibitors are known for the initial dip, which refers to the initial decline in GFR observed in the first 2 weeks of starting an SGLT2. A dip in GFR of less than 30% is not by itself a reason to discontinue the treatment. Physicians should also recognize that the lowest point in GFR occurs early after an SGLT2 inhibitor is started, and that the initial dip in GFR partially reverses over subsequent 6 to 8 weeks. In this table here, just some clinical considerations to note from an SGLT2 inhibitor. We already discussed the initial dip in number 1, but there are some things with chronic kidney disease that with patients that we have something called the sick day protocol, which helps patients that when they are sick, how to replenish, what medications to use, and so forth. Also to note, if a patient is diabetic and on another diabetes medication, such as insulin or other medications, is to basically decrease or take off the other insulin medications or diabetes medications and basically keep the SGLT2 inhibitors. The third class of medications in preventing chronic kidney disease progression are the mineralocorticoid receptor antagonists. We have spironolactone, allopurinol, and finerenone. They can be subdivided into categories of either steroidal or non-steroidal. Spironolactone and allopurinol are our steroidal mineralocorticoid, while finerenone is our non-steroidal MRA. Of these options, only finerenone is the FDA approved for use in kidney and heart protection. Spironolactone and allopurinol have shown potential benefits in patients with potential chronic kidney disease in reducing an albumin. However, they have had variable outcome results on kidney outcomes such as GFR decline and end-stage renal disease and kidney death. There has been limited landmark trials researching the use of spironolactone and allopurinol for kidney and cardiovascular protection, and these trials have had limited use as either the kidney or the heart endpoint. Furthermore, allopurinol has that contraindicated in patients in type 2 diabetes, hypertension, and microalbuminuria, which basically takes out all of those patients that would be using it for chronic kidney disease. Going into the finerenone background, it works by binding to the MRA receptors in the heart and kidney, where it blocks receptors to prevent inflammation and fibrosis. Finerenone has equal distribution between the heart and kidney, which is different than the steroidal MRA, where they can move into a more concentrated in the kidney. Finerenone received FDA approval for reducing the risk of GFR decline, end-stage renal disease, cardiovascular death, non-fatal MI, and hospitalization for heart failure in patients with chronic kidney disease attributed to type 2 diabetes. These indications are specifically attributed to patients with chronic kidney disease and type 2 diabetes. One thing to know about finerenone also, it has no active metabolites and shorter half-life, which actually decreases the risk of getting hyperkalemia. The guidelines have been updated to reflect finerenone MRA to be used in patients with type 2 diabetes. The ADA 2023 guidelines recommend initiating finerenone in patients with type 2 diabetes and chronic kidney disease with albuminuria who are on a max tolerated dose of a RAS inhibitor. So you max dose the RAS inhibitor, then you add the finerenone if indicated. The KDIGO released the chronic kidney disease and diabetes guideline in late 2022, recommending initiating finerenone with the metformin and SGLT2 inhibitors in patients with type 2 diabetes who are still experiencing albuminuria. And then the ADA and KDIGO also released a consensus statement with the same recommendations as the KDIGO guidelines. And then with all this info, it is a guidance, and some patients may have a contraindication or adverse events that prevent the use of RAS inhibitors or SGLT2 inhibitors, where finerenone can actually be used early on in the algorithm. Some strategies to control hyperkalemia and chronic kidney disease really have to follow a patient-centric approach. Like we said, there is no established guideline or census on how to manage hyperkalemia in these patients. We have a variety of options on how to manage hyperkalemia. And they're displayed here on the slide. And we really have to take in consideration for each individual when determining the best approach for the individual. So either discontinue drugs that increase hyperkalemia risk if possible, prescribing a low potassium diet, prescribing diuretics and when GFR is less than 30, correcting metabolic acidosis in patients with chronic kidney disease, and if required, initiate therapy with a low dose ACE inhibitor or an ARB, and then monitor it. And then gratefully, we do have some new potassium binders that may offer potential option to continue RAS inhibition in patients who need these therapies. Other agents that we'll briefly go over just to be cautious in patients with chronic kidney disease, such example as medications used to manage lipids. There was a meta-analysis of individual participant data from 28 randomized control trials that look at the impact of renal function on the effects of LDL cholesterol lowering with a statin-based regimen. It showed that statins reduce hepatic cholesterol synthesis and proteinuria, but do not appear to slow chronic kidney disease progression. It did show to significantly reduce all-cause and cardiovascular mortality in persons with CKD. However, starting a statin is not indicated for people on dialysis. Based on the most recent KDIGO guideline, statin use is recommended for all non-dialysis chronic kidney disease patients greater than or equal to 50 years of age, regardless of stage of disease or the presence or absence of albuminuria. For patients who are not on dialysis and they are between the ages of 18 and 49 years of age with an estimated risk of greater than 10%, it's recommended to initiate a statin. The use of standard doses of statin appears safe among patients with chronic kidney disease and does not require any special monitoring beyond that. More intensive statin regimens have not been well studied in patients with chronic kidney disease, and there is a concern that this population has a higher risk of adverse events related to the medication. This increased risk is thought to be due to a part of decreased renal excretion. As a result, cardiovascular benefit of high-dose statin needs to be weighed against increasing the risk in this patient population. Also, fibrates are not recommended due to AKI adverse events. It has shown to transiently raise serum creatinine increase rather than decreasing GFR. This is based off the SHARP trial. And then basically a significant lower incidence of cardiovascular events occurred in the treatment arm. The most recent KDIGO guidelines suggest statin with Zetia as an alternative to statin monotherapy, especially in patients with GFR less than 60. Additional medications that require dose adjustments in chronic kidney disease, you have metoclopramide. When using it, it's recommended to decrease the dose by 50%. If the GFR is less than 40, because it could accumulate and cause some CNS symptoms or extrapyramidal movement disorders. Another one is digoxin. It is 70% renally eliminated, also a reduction between 30 to 50% as a loading dose. And then you do maintenance dose reduction based on kidney function and ideal body weight. In terms of antibiotics, most of them do require renal dose adjustments. Bactrim, which is the most commonly prescribed, may increase serum creatinine slightly. Bactrim works by inhibiting a particular cationic transporter in the proximal convoluted tubule, which is also responsible for creatinine secretion. By doing this, serum creatinine elevates without an actual decrease in GFR. In addition to an elevated creatinine, Bactrim is also associated with hyperkalemia. The mechanism is basically felt to be a decreased aldosterone-mediated sodium reabsorption through the epithelial sodium channel in the collecting duct. So it's recommended to avoid use in older adults with creatinine clearance less than 15 and reduce it if creatinine clearance is between 50 to 29. Reduce the dose if it's between 15 to 29 due to the risk of worsening renal function and hyperkalemia. Be very cautious in older adults with decreased creatinine clearance and if they are on an ACE inhibitor or an ARB, because again, the risk of hyperkalemia. NSAIDs are associated with direct nephrotoxic effects that includes a significant decrease in GFR and renal vasoconstriction mediated by renal prostaglandin inhibition. They have been known to cause interstitial nephritis, nephrotic syndrome, and glomerulonephropathy, among other conditions. NSAIDs have been associated with hypertension, hyponatremia, and edema due to their effects on the distal renal sodium reabsorption and antidiuretic hormone secretion. The World Health Organization analgesic ladder has been advocated for the management of pain. That's what we use. It includes chronic pain in patients with chronic kidney disease. It involves the slow introduction and upward titration of analgesics, starting with non-opioids and progressing to weak, then strong opioids as required for pain relief. Let's start with acetaminophen. It's the first line analgesic for patients with advanced chronic kidney disease who have nociceptive pain. Acetaminophen is extensively metabolized in the liver, and only 2 to 5% of the therapeutic dose is actually excreted unchanged in the urine. Cumulative doses of acetaminophen likely does not affect CKD progression. It is relatively safe to give up the full dose of acetaminophen to patients with advanced chronic kidney disease. So that's like our first line therapy. Hydromorphone is metabolized primarily in the liver, which are excreted in the urine and accumulate in patients with reduced GFR. Methadone was traditionally used in the treatment of opioid addiction, but now increasingly prescribed for outpatient chronic pain patients. There are a limited number of studies showed that no significant accumulation in chronic kidney disease patient occurs, and it makes it a suitable medication for a renally impaired population. Lastly, fentanyl is rapidly metabolized in the liver, and only 5 to 10% of it is excreted unchanged in the urine. Its metabolites are considered to be inactive, so there does not appear to be any clinically significant accumulation of fentanyl when administered to patients with advanced chronic kidney disease. For managing neuropathic pain, the following table is a list of medications with altered doses in the setting of chronic kidney disease in patients, just for you to look at and use to help guide you. There have been a few studies in terms of herbals, vitamins, or supplements performed regarding complementary and alternative medicine in chronic kidney disease. While small studies have shown potential benefits of low dose, patients should be advised to avoid herbs if possible, especially if they are on immunosuppressive therapy. Many herbs can potentially interact with prescription medications or cause additional kidney damage in patients with underlying chronic kidney disease. This table right here lists herbs that may be especially harmful to chronic kidney disease patients, such as St. John worts and ginkgo. Others may contain heavy metals that are nephrotoxic or have ephedra-like compounds that are vasoconstrictive and can cause or worsen hypertension. Chinese herbal medicines that can contain aristocolic acid can cause severe and permanent kidney damage. So just to be very wary and cautious of being used, I don't recommend really any patients to be on it. Some strategies for improvement is, so what can we do in the primary care providers? What can primary care providers do to help prevent chronic kidney disease? Is to recognize and test at-risk patients, educate patients about chronic kidney disease and treatment, manage blood pressure and diabetes, address other cardiovascular risk factors, and monitoring GFR and albumin creatinine ratio. Again, as a reminder, the goals of care for a patient with chronic kidney disease include slowing the decline of kidney function, and this can happen through blood pressure control and using the appropriate medications for patient's diagnosis. The National Kidney Foundation Best Practices for Chronic Kidney Disease Identification, Risk Stratification, and Management came out with a one-page algorithm designed to help primary care providers identify chronic kidney disease earlier, help classify risk appropriate, and implement evidence-based management to slow progression and reduce cardiovascular complications. It aligns with the latest KDIGO recommendations. Just some key points from this algorithm, because we already discussed them, is to identify patients at risk for chronic kidney disease, screen patients using two tests. The NKF emphasizes that both tests should be performed together, serum creatinine and GFR. Diagnose chronic kidney disease. So CKD is present if either persists for greater than or equal to 3 months, GFR less than 60, albumin creatinine ratio of greater than or equal to 30. If neither criteria is met, repeat screening at least annually in high-risk patients. Also, it notes to classify chronic kidney disease using a CGA framework rather than just the staging that it used to be back then. And then to look at causes of kidney damage. So they had them the GFR categorized G1 through 5, and then what could be basically the causes to it. And then lastly is to initiate evidence-based management. So the algorithm recommends optimizing blood pressure control and optimizing diabetes management. That's we discussed with the use of an ACE inhibitor or an ARB when indicated, especially with patients who have albuminuria. Consider the use of SGLT2 inhibitors for patients eligible with chronic kidney disease. Considering the use of the non-steroidal MRA agonists such as finerenone on appropriate patients with diabetic chronic kidney disease and avoiding nephrotoxins such as NSAIDs, adjust medications dosed based on kidney function. The NKF algorithm also guides you on when to refer to nephrology when appropriate. Referral is recommended for patients with a GFR of less than 30 mils per minute, if they also have severe albuminuria, so greater than 300 milligrams per gram, a rapid decline in kidney function, if you're uncertain for cause of chronic kidney disease, if it's difficult to control the complications, if they have acute kidney injury, or if there's other complex kidney disorders. Those are all great times to refer to nephrology. Over here is an algorithm by KDIGO that you can use to help assist you in determining when it's appropriate to refer to nephrology. Basically, it's the same thing kind of with the NKF pull, but just a little bit more detail for you just to know. Right here is an updated algorithm that reinforces in identifying chronic kidney disease. It ensures appropriate use of kidney productive therapies, especially with SGLT2 inhibitors and RAS blockade. The key points on medications and chronic kidney disease is to optimize medication dosing, avoiding nephrotoxins, looking at medications that are renally eliminated, monitoring complications, collaborating with primary care and nephrology teams, trying to minimize fluid burden as much as possible because these patients are on a lot of medications with a lot of pills to take, and it makes it very difficult. Avoiding NSAID use. Some additional online resources. So the KDIGO guidelines provides a great starting point for evaluating medication appropriateness for commonly used medications of chronic kidney disease. But there are also additional decision support platforms such as Micromedics and Lexicoms, offers easily accessible monographs or prescription and over-the-counter medications that can help guide agent selection and dosing. The Natural Medicine Comprehensive Database is also a very useful resource to consider the safety of herbal dietary supplements, vitamins, and other herb medications to be used in chronic kidney disease. Thank you so much for your time. What questions do you have for me? I'm going to stop sharing.
Feel free to come off of mute and ask any questions that you have. Oh, go ahead, Chantale.
No, I'm sorry. I thought I was on mute. I don't know. I thought you were telling me to come. I thought you were telling me to come off mute. I was like, come on mute. You imagine I just did this whole presentation on mute.
Oh, no, I wouldn't have let that happen. All right. Well, if you think of any questions, you will have you have my information. You can always send it to us, and then I can send it on to Chantale, and she can connect with you. It's a little shorter day today, so you get a little bit of time back into your day. I do want to first of all thank Chantale for the wonderful information and presenting this grand round session. And just to remind, oh, there we go. We got in the chat, what do you think of GLP-1s?
In terms of use in chronic kidney disease patients, is that what your question is? Or in general, in the general population?
Feel free to come on unmute, Elaine.
Oh, sorry about that. In relation to the CKD and reducing progression.
Yeah, so
Um,
honestly, it's been a great medication to be used in chronic kidney disease, as well as actually we're using it a lot in our dialysis patients because, especially in our dialysis patients, because a lot of the patients to be on dialysis have to get I'm sorry, a lot of patients who are on dialysis are waiting to be on a transplant list, and
mhm,
a lot of the times they cannot qualify to be on a transplant list if they are obese. So this has been a great asset to use in our patients because they have lost a significant amount of weight and have actually been put on a transplant list with the use of this. Now, in terms of CKD
mhm.
patients, it's been also great. We don't really see it. We really prescribe, they've really only been prescribing it more with, uh,
Diabetics.
I'm sorry.
No, go ahead. I was thinking I've seen it a lot more with the diabetics and CKD.
So that's what I was going to tell you. So with diabetics, because it's still primary choice to use SGLT2 inhibitors because of the benefits of the
Mhm.
SGLT2 inhibitors on patients with CKD compared to the benefit of GLP-1. SGLT2 inhibitors provide way more benefit to patients with chronic kidney disease than the
Okay.
GLP-1. So if a patient needs the additional A1C treatment for to control diabetes, then we will add the GLP-1. But as a first line agent, CKD patients benefit way more from an SGLT2 inhibitor than a GLP-1. But when a patient goes on dialysis, you can no longer use an SGLT2 inhibitors there. And the reason for that is because they never studied it in patients with GFR less than 20. So that's why we do not continue it. So we just discontinue it. And this is where the GLP-1 agonist really plays a huge role in those
Good.
patients.
Thank you.
You're welcome. And we'll do for
I have a question quick. I was wondering, at Henry Ford, you had mentioned about primary care and their education on the latest guidelines. What has been, I guess, a workflow that has been built into the EHR, if any, that's been most useful in the early identification of patients with CKD?
Yeah, so we really haven't we're still working on that, and that's our
Mhm.
one of the process that we're working on. As of right now, we have literally a pharmacist in every single primary care setting, which has
Okay.
been great. And one of the things is I've been working with those pharmacists and basically trying to get to know these patients early on. So any patient who have hypertension, any patients who have diabetes, we're basically working on making sure that they're using the ACE inhibitors and ARBs, making sure that they are on the appropriate treatment, educating the physicians like, hey, you know what? Let's prevent the CKD from happening. Let's look at these patients who do have, let's just say, a family history of so and so. So we're utilizing, I'm working with the pharmacist and making sure that they're looking at the patient's medication list and optimizing these medications.
Oh, great. So, do you guys have any workflow like where it OPA where it flags you to have both UACR and EGFR done, or
We do not, not
okay?
yet. We are working on the of
Oh, cool.
installing that in the thing, yeah, into Epic.
Neat. Thanks.
Um, do you have any input into the Part D for the Medicare Advantage regarding which medications um, on the
Or
list?
on the formulary, like which
Yeah,
ones
the
will
formulary
cover.
because yeah, because there's like how I mean for Sega did go generic, but you know, the new one you were talking about is very expensive.
Yeah, so unfortunately, so Medicare Part D is very general, meaning there's Blue Cross, there's Humana Part D, they're all different types of insurances that have Medicare Part D. So they each also have their own formulary. So
Right.
so it can't be just general. So not so basically um
How
it
about the
just
half?
depends when yeah. So when you run it through, that's where they basically tell you like, okay, this one requires a prior authorization or it doesn't. Each one is different. So just because they have Medicare Part D doesn't necessarily mean that they're all the same type of list.
Right. Do you
You have
work
to go back to look at the actual insurance like company to see what their formulary is, what they
right? Do you have
require.
any input to the HAP one?
I do.
Sorry.
I don't. No, it's okay. I don't. I don't. But one thing I want you to know, actually, so I'm not sure if you guys are familiar with the Inflation Reduction Act that Biden came out with in
Yeah, the two.
2023.
Yep.
2023. Are you familiar with that? That
Yep.
Inflation Reduction? Okay, beautiful. So for those of you who are not familiar with the Inflation Reduction Act, so Biden, when Biden was in administration, he came out with, okay, like we are spending a lot of money on patients with chronic kidney disease and SGLT2 inhibitors. Like, what are the most costly medications? And they were like costing over $50 billion a year on these medications. And so what they decided to do, and the reason for this is not us, it's the companies, the pharmaceutical companies who make the medications. They're the ones who set the price, and that's why it's so costly. So when he came out with this act, the Inflation Reduction Act, basically he basically made that pharmaceutical companies and insurers basically come out with 10 lists of drugs each year. So this one just took in effect in 2026. I will actually show. Can I share my screen real quick? I'm going to show you guys which ones it was. Sorry, I just want to show you the list because I want to show you how much it decreased by. Okay, beautiful. Okie dokie. Okay, I'm trying to share my screen real quick with you guys. Share screen, share. Okay, there it is. Share screen. Okay. Can you guys see my screen?
Yes.
Okay, beautiful. So, and as of 2026, this year, these 10 medications, which basically you can see there's two SGLT2 inhibitors on there, Jardiance and Parixa, basically had these are the approximate discount. So they have to decrease their cost by 66%, and that's for Jardiance, and then for Januvia was by 79%. And part of the Inflation Act also said that insulin has to be all kept at $35. And every year following that, so this is a 2026. And then for 2027, these are the other drugs. So you're going to see Ozempic on there. They're still trying to negotiate the prices. So these are the next 10 drugs that are listed that they have to try to discount. So that's what they're basically doing to help basically cover affordability for these patients. Does that make sense?
Yes, thank you.
You're welcome.
And Chantale, there is another question from Donna. What would your advice be to a person with normal EGFR of 100 4 years ago and now is at 68? There has been a steady decline over the last 4 years.
Yeah, so I would just look at the patient's first history. So do they have hypertension? Do they have diabetes? What's the reason of the decline? So always trying to look at the primary situation. Looking at their lifestyle and then looking at their medications. So is there like a scenario you want to tell me if this person has a GFR, what was the cause of their GFR decline? And then how can we try to help with that? So just identifying the primary cause, basically. Why is their GFR declining? Hypertension only. Okay, so now looking at their medications and their lifestyle. Are they on a max dose of an ACE inhibitor or an ARB? Not sure. Okay, let's take a look at that. And then if they are, like we said, the next option would be a dihydropyridine calcium channel blocker. Again, the most important thing is dihydropyridine calcium channel blocker should not be used alone. Oh, I'm not sure why would they. So I'm not sure why they would say not to worry about the decline. We need to know why they're declining. I would worry.
Right. So, just randomly, with this decline, because with all of these in services with the kidney, the topic of kidney disease, you can see in charts where, that albumin creatinine ratio, so it's very interesting to me that these types of numbers aren't looked at in patients. They wait, or it seems as though it's just bad, and then that's when they're looking at it versus looking at certain trends, and like you talked about today, the different things, the health conditions that patients have that can lead to this. It's not just kidney, there's so many different players in it. So I just find it interesting.
Yeah, because you're not just born with kidney disease. There's something that caused the kidney disease. And
Right.
that's why I would like to know. So they have hypertension. Okay, but I'm just saying not to worry about it. But if let's just say this was my grandma or my grandpa, like, okay, like, no, I am going to worry about it. Why is my kidney declining more and more over the years and we're not doing anything about it? So I have hypertension. What medication I'm on? And remember, one of the things I said earlier is it's very important to not use a dihydropyridine calcium channel blocker alone because it can actually worsen kidney function.
Okay.
To use it in conjunction with an ACE inhibitor or an ARB. Yeah.
So would you say, just like you said, that there are pharmacists embedded, in primary care offices and things, but outside of, say, Henry Ford, a lot of primary care offices don't have that. So when we're talking to patients, would you agree that if, just looking at the chart and we see trends, to encourage patients to really bring up the topic and challenge their providers, hey, can we talk about this? And let's see what's going on. Would you encourage that?
Absolutely. And if someone basically, like, if this doctor basically tells me to not worry about it, me personally, I would just go get a second opinion. I wouldn't just leave that alone. So if the doctor doesn't want to, if that doctor doesn't like continue to encourage, continue to bring awareness, if they're
Right.
not with the front, and if just in case, then just get a second opinion.
Yeah. And I thought in one of the other, and maybe Terry can comment on this, I thought in one of the other in services, someone had mentioned that in the Henry Ford system, they're trying to create a combined um, the create ratio and, the EG, all to have one order set where it's just really easy for the
Press it
provider
and go.
to
Yeah.
just press it. And then all of those tests are ordered and it meets, it probably meet a lot of the metrics and things, but also the information for the patient and provider. So thank you for your presentation today.
Thank you. Thank you.
All right, any other questions? This has been great hearing all of the questions and the answers and I think sharing all of these helps everyone out in learning some information.
Absolutely. Thank you.
Thank you.
All right, so just as a reminder, our next grand rounds is August 19th. And this will be managing complications of chronic kidney disease, what to watch for, and when to refer. So it'll go a little bit deeper dive. We just kind of expand a little bit as we move forward. So I hope to see you all there. If you haven't registered, another reminder will go out the same way that you received the first grand round sessions. If you have any questions, please feel free to reach out to me. At the end of this, like I said, I'll send out the PDF of the PowerPoint and the information on how to claim your credits. Thank you so much for joining us and enjoy the rest of your day. I hope to see you next month.